Begin talking about the individual muscles of the body itself now. And so we'll start off with the axial skeleton and then move into the appendicular skeleton. For this particular set of notes, what I need you to concentrate on are the slides that actually have, in a sense, text on them. For the lecture, you won't need to be able to identify where the muscles are on like an image or anything, but they are here on the lecture for your ability to kind of review them as you go along. The images may be useful as well for studying, helping to study and finding the muscles for the lab portion, however, so you may want to use them for that. So when we look at axial muscles, if you remember back to the axial skeleton, where we had the skull, the vertebral column, and then the thoracic cage, that's where we're going to find these muscles of the axial muscles as well. So they have both their origin and insertion on the axial skeleton. So both of them are going to be found within them. There's going to be everything from muscles that are on the head and neck, so moving the head and neck and spinal column around, things for chewing. This is going to be muscles that are going to be there for the process of respiration, so within the thoracic cage, as well as articulating in terms of speech for the muscles themselves. So when we look at where we have the axial versus the appendicular skeleton, so essentially we have axial muscles in this region here. And so all of those ones are going to have their origins and insertions within that space on the body itself. So we'll start out looking at the head and neck for the muscles that we have here. And so we have those individual muscles of facial expression. We have muscles that can move the eye, so that we have the extrinsic eye muscles. We have muscles of mastication, our chewing muscles. Those, in a sense, are kind of near the facial muscles as well, as far as muscles of facial expression go. We then have muscles specific to the tongue, both intrinsic and extrinsic muscles there. And then we have muscles of the pharynx and down into the neck, attaching into the hyoid bone. So muscles of facial expression. These are the ones that obviously allow us to make different facial expressions. And so this is going to have an origin on the skull bones themselves, typically the facial bones. And so they're going to have that origin there, and then their insertion is going to be into the actual skin itself. And so they're going to go into that superficial fascia there so that it can move the skin rather than move bone for the muscles that are there. And so we have things like our epicranius, we have levator labii superioris, levator palpebrae superioris, orbicularis oculi, orbicularis oris, zygomaticus major, as well as minor, buccinator, and platysma. All there involved in the process of making facial expressions, causing movement of the facial skin itself. And so we can see those muscles within the dissected specimen itself. And as those muscles manipulate the skin that's been removed, they allow us to make all kinds of different facial expressions. And so we can see the different movements of each of the muscles themselves as they cause the different types of facial expressions to occur. So if we wanted to test the muscles of facial expression, we would basically just have the person do different types of movements. For the eyes, in order to move them, we have extrinsic muscles. And so these muscles are 4 sets of muscles, 4 of which are referred to as rectus muscles. So they're flat, long muscles. They go within the space that we find them. So we have a superior, an inferior, a medial, and a lateral muscle for the rectus muscles. And we're going to find them around the eyeball in the same thing. And so around that globe there, we're going to have one on the medial side, one on the lateral side, one on the superior side, and then one on the inferior side. The oblique muscles are going to come across the eye at an angle. So we have an inferior and a superior oblique muscle. Those are going to do essentially 2 movements in one because they are coming across the eye at an angle. So when we look at them, we can see that the superior rectus here is going to come back across the eye at an angle. And so when it pulls, it's actually going to pull the eye, and if this is where the pupil is in a sense, the pupil is going to end up going down and outward when that superior oblique contracts. The inferior oblique here on the bottom, when it contracts, it's going to cause the pupil to go up and out. So it's going to go in the opposite direction. So for the rectus muscles, typically in terms of motion, we're going to get kind of the motion that occurs, the same motion that occurs as the name of the muscle itself. And so things like inferior rectus, it's going to move the eye primarily inferiorly. Superior rectus, superiorly. The obliques, it goes opposite of their name. So superior goes inferior, but it also goes lateral at the same time. And same thing for the inferior oblique. So they have a little bit of a different motion as far as that goes. And here we can see really that oblique cut across the eye itself. It's not just going purely medial to lateral, it's actually coming across at an angle. And so we can see that on that particular drawing there. Our muscles of mastication are those muscles for chewing. And so primarily these muscles are our temporalis and the masseter. And so these are the big muscles that are going to close the jaw. And so if you clench down on your jaw, you can feel on the side of your head there, the temporalis muscle as it starts to contract. And so you can kind of feel and even see that kind of bulge out there. And same thing goes in the cheek. You see your masseter doing the same thing. Assisting with chewing, you have things like the buccinator muscle. Its fibers run anterior and posterior. That's more of a cheek muscle, helping to hold the food in. And then same thing similar to that of orbicularis oris, helping to keep the food inside the mouth itself. When we look at the tongue's job really is twofold. One, in terms of eating, we use the tongue to kind of move the tongue around and move our food from top to bottom to side as we're chewing it around and kind of keeping that food going in between the teeth as we chew. And then at the same time, we also use the tongue for speech. And so we're going to move it around inside the mouth depending upon the type of sound that we need to generate. The tongue's going to be pushed into different areas themselves. And so in order to do that, we have intrinsic as well as extrinsic muscles. And so the intrinsic muscles are those that are found within the tongue itself. And so these are the ones that are going to be able to curl the tongue, squeeze the tongue, push the tongue, while we're chewing and speaking and things like that. The extrinsic muscles are muscles that are essentially below the tongue within them, and these muscles are going to be utilized to essentially push the tongue out, force the tongue forward, push the tongue backwards within the oral cavity itself. So here we can see those muscles there of our extrinsic muscles, and then our intrinsic muscles within. Posterior to where the tongue is, we have the pharynx. And so the pharynx has the unique job of essentially being the delivery system for both air down to the lungs as well as food down to the stomach. And so it has to be able to generate contractions during both of those processes to make sure that different areas are opened and closed at different times for those issues that we have there. We don't want to be swallowing and try to breathe in at the same time. So we're going to move things kind of out of the way itself. And so one of the big things is that the pharynx is going to be the portion where we initiate the swallowing reflex. And so as the food gets pushed back in towards the pharynx, it's going to set off a series of reflexive contractions that's going to direct that food into the esophagus rather than down into the trachea or the larynx before it on there. And so in so doing, it's going to elevate the soft palate. Soft palate's going to go up. It's going to tense the palate itself so that food and liquid does not bubble back up into the nasal cavity. We keep it down there in the oral cavity. So many different muscles involved within the pharynx itself there. The neck muscles, these are basically our superficial muscles that we see in and around the neck itself. This is going to allow us to do flexion and extension and rotation of the neck, as well as lateral bending to either side for the neck itself there. These neck muscles are going to control things like the mandible, in addition to the actual spine itself that is there. And so when we look at the anterior muscles, the kind of the big ones that we look at are the sternocleidomastoid. And so we have the big sternocleidomastoid there. Deep inside the neck here, we have our sternohyoid. And so sternohyoid is going to run down the front of the neck there, kind of a deep muscle that's there. See it running on both sides there. We have other muscles like the trapezius running along there as well. Except for the trapezius is not truly a axial muscle because it does have part of its insertion over on the clavicle here. So it's part of the appendicular skeleton itself as far as the muscles are concerned there. And then most of the other deep muscles we don't really talk about too much in terms of the class, simply because when we go to look at them on the cadavers, they're very deep and they're not dissected out. Another view, we can see the sternocleidomastoid again. So when sternocleidomastoid contracts, it's going to cause rotation to the opposite side. So when this left sternocleidomastoid is contracting, it causes right rotation. If we were to use both of them at the same time, we would get flexion. On the posterior side, very complicated set of muscles along the back side of the neck itself. We've got many, many different muscles that are all aligned and give us all of the individual small movements that occur within the neck itself. And so a very complicated process. We kind of take for granted what actually has to occur in terms of muscle contractions in order to get us our head and neck to turn and also just stay on top of our shoulders. In and around that vertebral column, we just saw some of them that are there in the neck. And the majority of all those, most of the time, are actually covered over by trapezius. And so the muscles there, we had trapezius removed in order to be able to see these muscles. The muscles themselves are in and around the spine. They're going from spinous process to transverse process, transverse process to transverse process, essentially making all of those connections in between all of the vertebrae themselves that are there. On the posterior side, on the spine, along the spine itself, we have muscles that are referred to as the erector spinae muscles. And so these are the superficial muscles. These are kind of what you would think of as your back muscles themselves. And so this is kind of that ridge that's right along the spinous processes. So we have the spinous processes there, and then there's usually kind of like a ridge of muscle that's just lateral to them on either side. On this side here, they've been removed. All of those muscles have. And so all of that erector spinae muscles come together to give us extension of the spine in this particular area. There's not really a whole lot of flexors here because the majority of the flexors are coming from the abdominal muscles in order to cause that flexion to occur there. You're going to see some of the deep, smaller muscles again in and around the vertebrae themselves, running from spinous process to spinous process, running from spinous process down to transverse process to transverse process, and so on. Lots of little tiny muscles that, for the most part, we never have to think about contraction. There are our postural muscles. They're the ones that are working when we need to maintain our normal posture that's there. For respiration, we have the muscles for respiration itself are primarily the diaphragm, but we do have some extra muscles that can be called upon at times, the intercostal muscles, both the internal and the external intercostals. Ironically, again, here they work in opposite to their name. The external ones do inspiration and the internal ones do expiration. So they're going to work at different times for that process. Inhalation is a very active process, and so we need to have muscle contraction in order to do it, versus exhalation. Basically, once the muscles relax, they're going to allow for the muscles to just relax, and the thoracic cage is going to, in a sense, kind of fall back down. And the majority of the time for inspiration, we use the diaphragm. So the diaphragm is our muscle for inspiration. It's a dome-shaped muscle sitting and dividing the thoracic and abdominal cavities themselves. It's our only physical barrier within the abdominal pelvic regions. That's there. This muscle is the one that we use for the primary breathing muscle itself. And so restful breathing is going to use this big diaphragm that's there. And so it has muscle fibers, and then it also has a very large aponeurosis. And so it has this big tendon here in the center that's there for the muscles themselves. Through it, we're also going to have to be able to get things in through the diaphragm, things like the esophagus is going to have to go through there. The inferior vena cava is going to have to be able to make it through there. And then the thoracic aorta turning into the abdominal aorta as it comes down through the diaphragm as well. Here we see those intercostal muscles. And so we have the external and intercostal muscles. Those are going in through the ribs themselves. And so in between the individual rib bones, one on the internal side and one on the external side. And they go at opposite directions to one another. The abdominal wall, we have the very obvious rectus abdominal muscles. Pretty much everybody is familiar with those rectus abdominal muscles that are there in the abdomen. But on either side of those, or on the sides of them, we have an external oblique and an internal oblique muscle. And so they're going to be coming, whereas the rectus muscles are in the center, there, and we have the rectus muscles. The oblique muscles then come in at angles on the sides of those rectus muscles. And there's an external one and an internal one, and they go at opposite directions of one another as well for those. And then lastly, we have a transversus abdominis muscle, which comes across the abdomen as well. That linea alba that's there is essentially the connection between the two muscles of the rectus muscles right down the center. And so that's what's going to essentially allow for that connection between the two sides of the abdominal muscle. And so the linea alba runs right down in here as far as the abdomen is concerned. And that linea alba is important because this is where oftentimes umbilical hernias can start to begin from in that particular area there. The oblique muscles come into that similar aponeurosis as well. Here we have the external obliques. Those muscles run from lateral towards medial, kind of the same direction as if you were putting as your fingers go if you're putting your hands in your pockets. The internal obliques come back the opposite direction. And then the transversus abdominis comes across and goes straight across. And so all of those are supporting muscles for tensing the abdomen when we do things like bend down to pick something up. Down at the bottom of the pelvis, we have a pelvic floor as well. And so we have muscles that are going to essentially, for lack of a better term, keep everything from falling out of the pelvis. And so we don't want anything to come down through that pelvic floor itself. And so it is made up of muscles that are going to allow for everything to kind of be held inside in a sense. That's there. And so these muscles lie within the bottom of the pelvis. And so we have several different muscles that are there, creating that floor that is there. And so here we have a female that's there. And so part of the muscles that are there, the levator ani muscles that are in the bottom there of the pelvis itself are going to help with part of the Kegel types of exercises and things like that. And so as those contract, that kind of pulls the pelvis back up once again. But all of the muscles that are here are able to help that pelvic floor and keep things from kind of pushing down too far. For the appendicular skeleton, now we look at all those muscles that are going to essentially have at least part of their origin insertion in the appendages themselves. And so they're going to be out there in the appendages. These are going to move the arms and the legs. These are going to help with the shoulder girdle and the pelvic girdle. And so they're going to be allowing them to move there. They typically have either a synergistic effect to one another or an antagonistic effect to one another. So if one muscle does flexion, the other muscle may do extension. That's there. And of all the muscles, these are some fairly large muscles, and they make up some 40% or so of all the muscles that we have in the entire body itself. So the upper limb, we have the pectoral girdle, and so this is going to be the muscles that attach into the shoulder itself, and into the pectoral muscles and coming out towards the clavicle and the scapula. And then we have those muscles of the shoulder itself, so the glenohumeral joint. We then have our muscles that control the elbow, and then we have those muscles that control the forearm and the wrist as well. So the pectoral girdle is essentially the chest in a sense, and so everything from the anterior side towards the back, the posterior side as well. These are going to have origins on the axial skeleton. So just because it's appendicular doesn't mean that everything has to begin and end on the appendicular skeleton. But we have at least an origin here on the axial skeleton and coming down into the appendicular skeleton. As far as the pectoral girdle goes, remember back when we talked about bones, the clavicle was really our only bony connection between the appendicular skeleton and the axial skeleton of the upper limb. So that's going to be our attachment point there, and it's going to be an important process for us to keep in mind as we go along. But some of the other muscles are going to insert into the scapula as well for those. Many of these muscles are relatively large, so things like the trapezius, the pectoralis major muscle as well, and part of the pectoralis minor on the coming into the scapula also, that's there. Coming into the scapula as well, on the medial side we have our rhomboids, and then the serratus anterior. And so they're going to be able to move the scapula in different directions, kind of over the rib cage itself. That's there. And so we have our rhomboids. We have levator scapulae running with the rhomboids themselves. And so that comes off of the angle of the scapula there and comes up towards the skull. Trapezius covers over basically everything. Trapezius, big broad muscle, rather large triangular shape of a muscle as it connects all the way from the skull at the superior end all the way down to the lower thoracics and then out to the spine of the scapula on the lateral side there for that one. And so lots of muscles there. We have the pectoralis minor, which is deep to pectoralis major, whereas the pectoralis major actually inserts into the humerus. Pectoralis minor inserts into the coracoid process here of the scapula. So it's going to have that ability to move the scapula there. Serratus anterior comes into the lateral border there along the side. So in order to move the arm and sort of in order to move this appendage, we have certain muscles as well. And so for the abductors of our shoulder, primarily we have deltoid. And then helping out with this, we have supraspinatus. But supraspinatus is going to be a synergist in this process. For adduction of the shoulder, so bringing the arm back in towards the body, big ones here are the pectoralis major and latissimus dorsi. And then helping out in the process, we then have infraspinatus and coracobrachialis for those muscles that are there as well. And all of those do adduction. So here we have our pectoralis major. This is going to do adduction of the shoulder. So that's going to bring the shoulder back in. We have coracobrachialis helping out doing the same thing. For abduction, we have deltoid in there doing a primary job of elevating the shoulder there into abduction. And then on the posterior side, we can see trapezius here helping out with shrugging of the shoulder and pulling that upwards as well. In addition to helping out the deltoid, so deltoid doing our abduction, we then also have supraspinatus. Supraspinatus is going to work more so when the shoulder is kind of out towards us at about 45 degrees between fully anterior and to the lateral side. So it helps when our shoulder is kind of out in this direction over here. And then we've got infraspinatus helping out with rotation of the shoulder, pulling that back around into lateral rotation. At the elbow, on the anterior side of the upper arm, we have biceps brachii and brachialis. Both of those muscles are in the upper arm. And so biceps brachii here, it has two heads to it, hence the biceps portion. The short head goes up to the coracoid process. The long head comes up and goes through the intertubercular groove and then goes up to the glenoid cavity there. In order to see brachialis, we have to get rid of biceps brachii there, and we can see brachialis deep to here. And so it only crosses the elbow. Brachioradialis is going to come down across the elbow here, and that's kind of that muscle that kind of pops out by your elbow as you do flexion of the elbow as well. And then on the posterior side, all we have there is triceps brachii. And so opposing flexion, we only have one single muscle there, the triceps brachii. And it has obviously three heads. And so we can see the lateral head and the long head that are there, and then the medial head underneath there. So if we dissect out the lateral and the long head, we can then see the rest of the medial head here underneath. And that's going to be helping with pronator teres. And so pronator quadratus and pronator teres are working together for our pronation at that point. The wrist and the fingers get helped out by muscles that are primarily in the forearm as well. And so we have flexors of the wrist and fingers, and then we have extensors. So the flexors are going to be on the anterior side of the forearm. The extensors are going to be on the posterior side of the forearm. And so we'll see them in a couple of different areas there for each one. That's there. And so when we look at the muscles here, we look at the anterior side, we can see brachioradialis coming down and helping us out with flexion of the elbow. And then doing flexion of the wrist, we have flexor carpi radialis, flexor carpi ulnaris are the two major ones there for the wrist. Also going to be doing abduction and adduction of the wrist there as well. And then deep underneath, we have our flexor digitorum superficialis helping out, so that we've got to get under those other muscles to really be able to see the flexor digitorum superficialis. Palmaris longus here isn't much of a wrist flexor, but it does help out with it some. But palmaris longus is unique because not everybody has one. If you take your thumb and your fifth digit, so your first and your fifth digit, your pinky and your thumb, oppose the two tips of them together and then do slight flexion of the wrist. If you see a tendon popping out there, right here in the middle of the wrist, that is generally palmaris longus. If you don't have one there, then you're one of the few that don't have one. For the lower limb, we then have muscles that are going to control the pelvic girdle, as well as go down and control the knee and the ankle and foot as well. These are the strongest muscles. They've got to bear basically the entire weight of the body itself. Think of just going up on your toes, and those calf muscles have to be able to lift essentially your entire body weight on there. Same thing with your thigh muscles that are there. Many muscles cross more than one joint here, whereas up in the upper extremity, the majority of all of our muscles cross only a single joint, but down here they cross more than one joint, especially in and around the hip. So for the hip itself, to be able to move it, we have thigh muscles that are going to be involved as well as muscles of the gluteal region. And so the biggest muscle that we have, gluteus maximus here, it's been cut in the picture, but gluteus maximus is going to be one of our big extensors that we have. Biceps femoris down in the thigh is going to help with this process. And so it's going to assist in the normal extension of the thigh as well. And then on the medial side of the thigh, we're then going to see, we can barely see here semitendinosus. Here we have part of biceps femoris, that's there. And deep down in here, we're going to see semimembranosus as well. So all of those are extensors of the hip. Flexors of the hip, part of them actually begin way up in the pelvis and get their start up by the lumbar spine itself. And so we have things like psoas major. That's one of those deep muscles that gets down deep into there to help with flexion of the hip itself. And then we have other muscles that are going to be within the hip area as well on the anterior side. And so we've got things like rectus femoris, we've got sartorius, and gracilis all helping with those kind of minor muscles that are in that area there. For abduction or abduction, we have gluteus medius. Gluteus medius is going to be right here. So we want to move our hip to the side, and so lean it off towards the side for us. We use that gluteus medius muscle. But gluteus medius is typically actually used for stabilization of the pelvis when we walk. It helps to keep our hip from kind of falling downward. And so it stops it from dropping down as we go on one foot. That's there. So here we can see our psoas major muscle coming down along the hip there. It gets joined by iliacus as well. And so both of them are hip flexors, deep hip flexors that we have there on there, along with rectus femoris on the anterior side there. Here we have our sartorius and then gracilis over here to find those there as well. Common muscle giving us problems, especially with runners, is tensor fasciae latae. And so this comes down and inserts into this big tendinous structure here, the iliotibial band. So all of this white in here, very, very strong tendon. And so we have this huge aponeurosis and tendon here, very, very strong structure, oftentimes gets very tight in runners. And so it's very difficult to stretch and kind of rub out or anything like that. On the posterior side, here we have the muscles of the hamstrings. And so we have biceps femoris. There's the long head and then the short head over here. Semitendinosus sits on top of semimembranosus. So the two muscles rest on top of one another there. On the anterior side, we have the extensors of the knee. And so we have our quadriceps muscles. And so the quadriceps are going to do extension. The hamstrings are going to do flexion. And so they're going to work in those two manners for that. The lower extremity is opposite of the upper extremity. So everything that's on the above the waist on the anterior side, for the most part, does flexion of the body, and then extension on the posterior side. But everything below the waist, everything on the anterior side just about does extension, and everything on the posterior side does flexion for the two that are there as well. So the quadriceps are actually four muscles, as the name implies, quad. We have two vastus muscles, vastus lateralis and vastus medialis, that are superficial. Deep to the rectus femoris muscle, we have vastus intermedius. And so those make up the 4 quadricep muscles themselves for knee extension. All of them insert into the quadriceps tendon, which then envelops the patella, which then gives the patellar ligament, which goes down to the tibia into the tibial tuberosity. On the posterior side, we have biceps femoris that we just looked at, and semitendinosus and semimembranosus all making up our hamstrings, doing flexion of the knee. So here we have the quadriceps muscles, rectus femoris right in the center on top, vastus lateralis, vastus medialis running along the sides, and then vastus intermedius is actually a deep muscle. This one is hidden by rectus femoris. Normally when we look at it on like a model or the cadaver, things like that. So flexors of the lower leg, we have our muscles that are going to be able to work in that realm for the body itself, as well as for the knee. And so for the ankle, we have gastrocnemius as well as soleus. For the knee, we have sartorius, gracilis, biceps femoris, and semitendinosus, semimembranosus. For extension of the knee, we have our vastus muscles and rectus femoris. Here we can see below the knee we have gastrocnemius. This is what we typically see as the calf muscles themselves. And then we have soleus, just deep to it. Let me erase that again. So gastrocnemius is superficial. Soleus is actually deep to it. It's actually quite a big muscle. Gastrocnemius does cross the knee joint. So in order to stretch it, we need the knee to be straight. But soleus doesn't go above the knee. So in order to stretch it, we actually have to have the knee slightly bent. If you're trying to stretch out like your Achilles tendon here, or the calcaneal tendon, or your gastrocs and soleus muscles themselves there as well. On the anterior side of the lower leg here, we have tibialis anterior, an important muscle for keeping the toes up, and so doing our dorsiflexion. So tibialis anterior there does our dorsiflexion. Doing plantar flexion, putting our toes down, we again have our gastrocnemius and soleus are our 2 main muscles. And then fibularis longus is a helper in that, another synergist in the muscles themselves. So gastrocnemius here has 2 heads, a medial and a lateral head there. And then soleus, if I was to kind of draw everywhere where soleus goes, soleus is kind of all the way up in here. So it's quite a large muscle. And so it fills in quite a large space there, in addition to the gastrocnemius that's there. And that concludes our muscles of the body that you need to know.